Recording in
I'm
progress.
thrilled that you're joining me in this program today. Brittany is on with us today for customer support. And so any questions for her that are more technical in nature, please put into the chat box, like access to handouts, anything along those lines. And Brittany will give you information on getting your CE certificates as the day goes on. Questions to me that are of clinical nature. If you look at your command bar or whatever it's called on Zoom, you'll notice way over to the right, there is one that says more. If you click on that, you'll see the Q&A box. And that's where I'll answer clinical questions for you. Okay. So with that in mind, let's get going. The first thing we're going to talk about this morning is management of menopause and perimenopausal symptoms and the latest treatment options. A little bit more about my background. I am the founder of Fitzgerald Health Education Associates. Very proud of the work that we've done with helping about 180,000 NPs achieve certification. But what a lot of people don't realize is we also have university courseware and a very robust program of ongoing continuing education for nurse practitioners. And I know a number of you who are with us today are Passport members, so welcome. And that we really take our commitment to advancing NP practice very seriously, which has actually helped the company receive a lot of attention and many awards for how we've helped advance NP practice. My clinical practice has been in a federally qualified health center in a small city about 30 miles north of Boston, Lawrence, Massachusetts. And I've actually been there my entire NP career, see everything that comes through the door, pregnancy, little ones, ones in the middle, older ones, and the like. And I am a primary care and urgent care provider. That practice has been maybe about 40% urgent, same day urgent care, 60% primary care, and then another day the ratio will be flipped depending on what comes through the door. I hold a faculty position at Case Western Reserve University, which is where I did my doctoral studies. And I work with them on a global nursing leadership initiative, particularly in the area of entrepreneurship. I sit on the editorial board of a number of different journals, and I'm a member of the Pharmacy and Therapeutics Committee for Mass General Brigham Healthcare, which is one of the largest health insurance plans in the New England area. So some disclosures to keep it real, keep this a CE-bearing program. No real or potential conflict of interest to disclose. No experimental medications will be presented. However, I will talk about specifically in this program the use of SSRIs, SNRIs, and gabapentinoids that are not FDA approved for the treatment of menopausal vasosymptoms. This will also be discussed. So let's take a look at this when we're talking about management of menopausal symptoms. And I just want to say this a little bit ahead of time here. I will be going over the latest recommendations from the North American Menopause Society. And so what I'm really focusing the program on medications that have and interventions that have been very well studied. And so bear that in mind so that this program can be CE bearing. So upon completion of the program, the participant will be able to describe the physiologic changes that lead up to and during menopause and their clinical impact, identify the role of hormone therapy for the treatment of common menopause-related signs and symptoms, and then recognize the role of non-hormonal therapy for the treatment of common menopause-related signs and symptoms. And references will be throughout and at the end of the presentation. All right, what about menopause physiology? Well, first of all, menopause it's not a disease, but it is a naturally occurring state. And you might say, well, there's a great quote from I think it was the 1960s. It was one of the best-selling books in the 1960s, written by a male gynecologist, that just needs to be said, that talked about menopause in women being a living decay. Yeah, let's go and read his book. That sounds wonderful. Because what his statement was that humans are almost the only mammals where females will live for a long period of time in a menopausal state. And it's the average now is like at least 1/3 of the woman's lifespan, okay, in the menopausal state. It's now been discovered as well that there are certain whale species that the females live in a menopausal state for a long period of time. But when we look in the mammalian world, most mammals will die not long after they're menopausal. Something to ponder there. And the reality is the human body has not changed all that much in about 100,000 years. We were to run into a human from 100,000 years ago, they would look remarkably similar to us. They would. And back then, most people were dead by the time they were 40 through either injury or infectious disease. Now, what do we have? We have people quite routinely living at least double that. And to be honest, we expect people to live at least double than that. So when we're looking at this, the human body from a viewpoint of how it has evolved is not tremendously adapted to living in a menopausal state, but it still is considered a physiologic state. So in North America, the median age for natural menopause is 51 years, and age under 40, that's considered to be premature menopause, 40 to 45 early, and 55 and older late. And remember that menopause is defined as 1 year post last menstrual period. Okay. Age is affected by genetics. Tobacco use is a huge risk factor for earlier menopause. Possibly ethnicity contributes to this as well. And it's not like non-menopausal one day, menopause the next day. It is a typical transition that occurs over a number of years. So what are the stages of menopause? There's the late reproductive phase or premenopause, where often this is where a woman will report changes in the menstrual cycle and flow. If we were to check FSH and estradiol levels, which I'll talk about that in a little bit, whether that's needed, not needed, or the like, they'll be variable. And really, one of the things that starts to happen is FSH, follicle stimulating hormones, often go really, really up. And the reason why they go up is that the aging ovaries are not, sorry about that. The aging ovaries need, shall we say, a little bit more of a boost to cause an egg to be released. And estradiol levels tend to go down as well, particularly the week prior to the menses. And this is what you'll hear from a woman in this stage. And I'm going to use the term woman for female assigned at birth, okay? And women of that age, what they'll often will say to you is, this doesn't make any sense. My periods are really regular. They are a little different than they were when I was like in my early 30s. I'm in my mid 40s now. This doesn't make any sense. I have a period every month, but I have hot flashes the week before my period. And that is in part due to the lower estradiol levels. Perimenopause, increased cycle variability. FSH is up. Again, the estradiol is variable and symptoms are more likely. One more time, one of the times most likely is the premenstrual week. And then postmenopausal cessation of menses, one more time, definition of menopause is 1 year after the last naturally occurring menstrual period. Estradiol and AMH and inhibin are all low. Progesterone levels are continuously low, and FSH is super, super high at that point. So like I said, hang on to your thought on whether we should be checking these hormonal levels or whether we should be using labs to really, quote, diagnose menopause. So during the reproductive age, ovaries are stimulated by FSH and LH produced by the pituitary gland. And then what happens is ovarian follicles enlarge and produce estradiol. That turns off the FSH LH production. With aging, fewer follicles remain to be stimulated by FSH, and estradiol levels go down, along with a decline in androgen inhibiting progesterone. Without this negative feedback loop by estradiol, and FSH and LH levels remain elevated. And one of the things that I'll often will say to patients is, one of the things that's going on is this gland in your brain called the pituitary, and particularly the front part of it, is producing more of this hormone called FSH and LH. And what it's trying to do is get your ovaries to ovulate one more time. And your ovaries are saying, you know, we're 50 whatever years old, we're just not going to do that anymore. And perimenopause and menopause, one more time, irregular menstrual cycles, these alterations in FSH, LH, they stay high, estrogen, progesterone levels are low, and you get the cessation of the menses. So what are some of the other physical changes that go with this? And the last time I presented this program, I was in a live classroom in person with a group of healthcare providers that were predominantly women, as we tend to be in the nurse practitioner world. And there was a good deal of eye rolling and sighing as I went over the physical changes that go with menopause. The breasts tend to diminish in size. The vulva, the size of the vulva literally diminishes because, and this is a lot has to do with the change in estradiol levels. Thinner skin, vulva, you'll see hair loss. What can happen within the vagina? The epithelium maturation goes down. The results in lack of glycogen. The pH will go up in the vaginal vault. And remember, when you're looking at the woman in the reproductive years who is having menses, and her ovaries are producing estrogen in higher volume than what we see in the in menopause, what you'll have is during the reproductive years, the vaginal pH is like the high 3s to the low 4s, and it goes up to over 5 post-menopause. And that low vaginal pH during the reproductive years is actually really helpful to avoid certain infections like UTIs, because it's not just the vagina, it's the whole periurethral, perineal area. And that more acid pH of the reproductive years is really quite toxic to a lot of bacteria, viruses, and the like. Now, in the menopausal years with a higher pH, more predisposed to infection, shorter, thinner, narrow vagina with a loss of rugae, issues with lubrication, the pelvic floor. There tends to be, and by the way, on the left, this is what vaginal epithelium looks like in a woman in the reproductive years. This is on the right, what it looks like post-menopause. And you see how much thinner, less robust, less plump the cells are. And the loss of lubrication is part of it. You could see an illustration here. And, you know, I think we've all seen this. Doing a pelvic exam might be time for a PAP or something along those lines. And a woman who is postmenopausal, you'll see that thinner vaginal epithelium and the loss of rugation that is seen in a younger woman. Pelvic floor, muscle tone is lost, predisposing to uterine prolapse. That's what we're looking at here in this illustration. And then particularly a woman who might have had a smaller cystocele or a smaller rectocele notices it gets bigger. It gets bigger. And so remember, with cystocele, we're talking anterior vaginal prolapse. Rectocele, it is posterior vaginal prolapse. What about vasomotor symptoms then? These often begin during perimenopause, and frequent vasomotor symptoms, or VMS, often persist on the average of 7.4 years or longer. Vasomotor symptoms, you know, I know there are a lot of colloquial terms for them, like private spring and, you know, just things where people are trying to make it funny. There's nothing funny about them. I know a woman who had her first major hot flash in her mid-40s in the middle of doing a big presentation to a group of people in business, and she thought she was dying. She made it through the presentation and kind of grit her teeth and made this through. And this was a presentation that was going to make a big deal in her professional life if it went well. And she was standing there kind of gritting her teeth, if you will, got through it, and then thought, well, the minute I'm through this, I'm going to get out of this room, go to the ladies' room, hide for a little while, and call 911 because I must be dying. She thought I'm having a heart attack or something like that. And then she thought it through and she went, damn, that was a hot flash. Okay. But affect quality of life. It may be associated with cardiovascular bone and brain health, because this is the body really reacting to these alterations in the different hormonal levels and the like. So this is the NAMS position paper on hormone therapy with the North American Menopause Society. It just came out relatively recently. And what do they have to say? First of all, remember, we all have a science background. What we all have to do is look at the research. And this is what their general principle is. No single trials findings can be extrapolated to all women, including the WHI, the Women's Health Initiative. And that according to NAMS, the Women's Health Initiative was the largest randomized control trial of hormone therapy for women aged 50 to 79 years, and its findings were therefore given prominent consideration. So let me just tell you a little bit about the Women's Health Initiative, because it was the biggest publication that came with the Women's Health Initiative was in 2005. Yes, I'm very well aware that was almost 20 years ago, right? And I'll give you a little bit of background about that. But you know how many of you are in primary care who are on this program today, but you might remember with diabetes, there's the DPP, the Diabetes Prevention Program or Project. I can't remember which one it is, but the initials are DPP. That was actually published in the late 90s. The late 90s, we still go back and look at the data from that. Now, why do we do that? You know, it's published in an entirely different century. Okay. Why do we look back at that in 1990? Because the DPP trial, there will never be a long-term observational trial like that. It was observational and intervention. There'll never be another trial like that ever done again. I could almost write you a guarantee on that one. And why not? In part because diabetes care has changed so much and the like. So what we do is we look back at that trial and say, okay, this is what we now know about diabetes that we didn't know back then. Incorporate that, but then walk away with some of the good stuff. Like DPP was the trial that really demonstrated that metformin can help prevent the progression from pre-diabetes to diabetes. That was never known before and would be safe to use. Okay. So the Women's Health Initiative was started in the early 90s. 2005 was its major publication. So it was a long-term trial, okay, long-term study. And we will still go back and look at that. Plus, the other thing is it's an extension study, and there are still 93,000 active participants, and more is being learned. So when you hear Women's Health Initiative, a lot of times what people will automatically say is, oh, that was the one that said, no. Hormone therapy for management of menopause symptoms, it really looks like it's just all bad. No, first of all, that's inaccurate. And second of all, we have to take out of it what works and then look at the flaws. And there were major flaws in the Women's Health Initiative, major flaws in its study design, who they included in the population that was studied and the like. Just one other comment on it. Women's Health Initiative, the big publication came out in, if I'm not mistaken, like June or July of 2025. I was speaking at a meeting. I wasn't speaking on hormone therapy. I was speaking on a meeting on something else, on some pharmacology topics. And it was about 2 weeks after the WHI was published. And it kind of rocked the world of what was being done with women who were having menopausal symptoms. And I remember making sure I read a really good summary of it, just in case I got questions about it. But I also looked at the program, and there was somebody who was speaking on menopause hormonal management at the same meeting. And I looked at this speaker's handout, and it was, of course, because it's a meeting in July, handouts were probably submitted like in April. It was all the old data and none of the new data. And I thought, oh, this poor soul had to revise their entire presentation on like probably a week's notice. So anyway, what were the limitations in the WHI? The only hormone therapy that was given was oral, because that's really all that was available now at that time. Now we have transdermal. There was only one estrogen form in dose, conjugated equine estrogen, i.e. Premarin, and this would be considered today at 0.625 milligrams, high dose Premarin, okay? And not lower dose. There is a 0.325 milligrams, which if Premarin was used, this would be the more common. There was only one progestogen given, and that was medroxyprogesterone acetate or Probera in only one dose, okay? Limitation on the enrollment side. The enrollment was limited to women with bothersome VMS, such as hot flashes, night sweats, who were age less than 60 or were less than 10 years from menopause onset. And the current guidelines view this population as hormone therapy's target population, but it did not include women with earlier premature menopause, whether that's naturally occurring or surgical. All right, so what about some terminology according to NAMS? ET is estrogen therapy, so that would be giving a supplemental estrogen. And by the way, you'll notice that the term HRT, hormone replacement therapy, has not been used for a number of years when talking about menopause, because anything that you do prescribe is not an exact replacement for what the body's no longer producing. EPT is combined estrogen progestogen therapy. Progestogen encompasses both progesterone and synthetic progestin. So an example of a progesterone would be micronized progesterone. It's quite similar to what the body naturally produces. And then synthetic progestins, we're really familiar with those because they're used in combined hormonal contraception, could include drugs like levonorgestrel, norethindrone, and the like. And by the way, what the body does with the synthesized progestins is biotransform them to a usable progesterone. Hormone therapy, as I mentioned, it's both ET and EPT. CC-EPT is continuous combined daily administration of an estrogen progestogen therapy. CS-EPT is continuous sequential estrogen progestogen therapy, and that would be cycling through the estrogen with a progestogen, whether it is on a more cyclic type of a therapy. TSEC. Now, this might not be a term you're familiar with because it's a more recent coined term. And this is tissue selective estrogen complex. And so that would be a combination of a select estrogen receptor modulator, a SERM like raloxifene or bazoxifene, and one or more estrogens, for there is a combination of the SERM with conjugated equine estrogen that in one formulation called Duav. That's the trade name on that one. All right. And by the way, I teach pharmacology. So what I have to do is say with tissue selective estrogen complex, well, or more with the SERMs, the selective estrogen receptor modulator. When we talk about an estrogen supplement, like estradiol, conjugated equine estrogen, whatever it is, when the body takes that in, it goes to all the estrogen receptor sites in throughout the person's body. So it will go into the estrogen receptor sites in the brain, in the back of the eye. I'll talk about that a little later, in the cardiac tissue, in the reproductive tissue, like the vagina, the vulva. So those are, and potentially that's all good because getting the estrogen into the brain might be kind of the key to helping with menopausal symptoms like hot flashes. Okay. But the downside of the estrogen supplement is it also goes to part of the bodies that we might not want estrogen to go to, like the breast tissue. Okay. Better not to stimulate breast tissue with estrogen after a certain age. Okay. I'll get to that in a moment with increasing rates of breast cancer and what the real numbers are. And also to the uterine lining, to the endometrium, which can cause endometrial hyperplasia. Something like a SERM, a selective estrogen receptor modulator. What that does is it will not go to some of the problematic estrogen receptor sites, like the breast and the uterine lining, but it will go to the others. So that's what's meant by selective estrogen receptor modulator. It's almost like a smart form of an estrogen. So what about vasomotor symptoms and hormone therapy? Remember, I'm now quoting the NAMS guidelines. Hormone therapy, estrogen with or without a progestin remains the gold standard for the release of VMS. Estrogen alone can be given to symptomatic women without a uterus. We are now referring to people as having a uterus or not having uterus. The old term was an intact uterus, which used to always make me think, what happened to some women? Their uterus exploded. Now, we're talking about women who had had their uterus removed. For symptomatic women with a uterus, estrogen progestin therapy, EPT, or tissue selective estrogen complex will help prevent against endometrial hyperplasia and endometrial neoplasia. So the progestin is there in part to help minimize the endometrial hyperplasia. And hormone therapy is also the most effective treatment option for genitourinary syndrome of menopause. And that's really what we're talking about with the lower reproductive tract issues and the signs and symptoms of decreased estrogenic stimulation of the vulvovaginal and lower urinary tract. So that's where you get into the burning, irritation, throughout the urethra. Remember, I think the urethra is the forgotten part of menopausal symptoms of vulvovaginal dryness, dyspareunia, urinary symptoms of urgency, dysuria, and recurrent UTI. Demonstrated effectiveness for prevention of bone loss and fracture as well. And by the way, the hormone therapy talking about here, we're talking about systemic hormonal therapy, not localized. I'll talk about localized a little later in the program. So what about clinician barriers to hormone therapy and patient barriers? So on the clinician side, deficient knowledge of the true evidence of efficacy and safety of hormone therapy. You know, many of you have been in practice as prescribers for less than 20 years. And so you probably never really heard during your NP programs about, oh, you know, look at the Women's Health Initiative, hormone therapy is terrible. But a lot of us have been around for more years than that. And what we were practiced in was a time where we thought, look, hormone therapy is really, really helpful. I would dare say in the 1990s, it was not uncommon to hear well-informed providers say, put a woman on hormone therapy as soon as she starts with hot flashes, stop when she's 75. You know, so you'd have women who were on hormone therapy for like 20 plus years. Okay. And then all of a sudden we had the Women's Health Initiative, and all of a sudden no one was prescribing hormone therapy, or hardly anyone. So now we know better. So that's what I'm going over here. Overestimation of breast cancer risk, misleading information about safety, lack of knowledge about risk of not treating symptomatic women, and lack of time for menopausal consultations. Amen to the last one, because it really does take a dialogue to have an informed conversation on benefits, risks, etc., of hormone therapy. And what I always think of from my own practice is when you go through the literature, and I believe in this is good science and all. When you go through the literature on prescribing hormone therapy, they'll talk about an ongoing dialogue between the clinician and the patient, and benefits versus risks, and having the patient go home and do their own homework and all, and participate in the decision-making process. Yeah, in a perfect world, that's what would happen. You might start discussing this even early mid-40s as a woman starts going towards naturally occurring menopause. Okay, I agree. And then I always think of one of my patients who came in. Well, actually, she wasn't my patient, but she came in for an urgent care visit. And it was a bitter cold February evening in Eastern Massachusetts. And I think it was probably like in the high teens, low 20s. I mean, it was a cold night, a cold night. She comes in, she's wearing kind of like, she's got a winter coat, which she takes off. But underneath, she's wearing like a tank top and a pair of very lightweight pants. And she is soaked in sweat. And she looks at me and she says, I want that hormone stuff so I stop having these hot flashes. I'll sign any paper you want so that I won't sue you if I read about it. I know I could get a blood clot, I could get breast cancer, I could get this and that. She clearly had done some reading on it. She said, I will sign any paperwork you want so that I promise not to sue you if I get any of those, but you've got to help me. And so that's the other part of it. Yes, it needs to be the dialogue. It does need to be the dialogue over time, but you will also get patients that are that desperate. They are that desperate. So we did work out something for her that night. She had some real contraindications to getting an estrogen-based therapy, and that she was a very heavy smoker. So I'll talk about what I did give her, and it was helpful. Okay, what about patient barriers, fear of breast cancer, lack of knowledge, and misperceptions about hormone therapy, misleading information from the media and community, poor social opinion on hormones, and possible adverse effects. And it looks like only about 20 to 30% of women who would be eligible for hormone therapy actually do get it. So when we look at this, recognizing some of the benefits from the WHI and some of the risk with hormone therapy, what you can see here is, excuse me, there are some things that we don't even think about as possibly being helpful. So the first arm, remember, the only hormone they used was CEE, conjugated equine estrogen. So the red is when stuff went up. All right. We can't sugarcoat this anyway. There was an increased risk of DVT and an increased risk of PE when there was conjugated equine estrogen and CEE plus the MPA, the progestin, okay, to go along with it. Estrogen is pro-thrombotic. No two ways around it. No two ways around it. You'll also notice in the estrogen alone trial, there was more benefit for like reduction of diabetes risk, reduction of death from any cause was a little bit better in the estrogen alone trial. Coronary heart disease rate was lower in the estrogen alone trial. Now we go and we look at the CEE plus the MPA, and you see a bump up in the things like coronary heart disease, stroke, and in breast cancer. Interesting. But look at this with the estrogen alone, the breast cancer risk is actually lower. Now, one of the things to remember, this was pretty high dose estrogen compared to what we would use now. And you might say, well, what the heck? What was the reduction in the diabetes risk? Estrogen is insulin sensitizing. So that is why the diabetes rate was down. So back to NAMs and their hormone principles, the risk of hormone therapy differs among women. It will be dependent on a number of factors: the hormone therapy type, dose, duration of use, and route of administration, timing of initiation, and whether a progestogen is given or not. And the treatment should be individualized to maximize benefits, minimize risks, and periodically reevaluate. For women under the age of 60 or within 10 years of menopause onset without contraindications, the benefit versus risk ratio appears to be favorable, with hormone therapy for bothersome vasomotor symptoms and the prevention of bone loss and reduction in fractures. Longer duration therapy is more favorable for estrogen therapy rather than estrogen progestin therapy, and per WHI, detectable breast cancer risk after 3 to 5 years of EPT. That's when the breast cancer risk starts to go up after 3 to 5 years. If you're doing estrogen with a progestogen, no breast cancer risk detected after 7 years with estrogen alone. And the only women in that group that had estrogen alone were women who had not had their uterus removed. And remember, back then when the WHI was done, there were a lot more women who had undergone hysterectomy than currently, because one of the things we also need to keep in mind is things like endometrial ablation were not available for women having very problematic heavy menses. Another thing that was not available were things like embolization procedures to help shrink problematic uterine fibroids, things along those lines. So there were a lot more women who had undergone hysterectomy than currently. For women who initiate hormone therapy more than 10 to 20 years from menopause onset or age 60 years or older, less favorable risk versus benefit ratio than younger women, greater absolute risk of coronary heart disease, stroke, VTE, and dementia. Something to just keep in mind. If you've got a woman who's 10 to 20 years after menopause onset, that is a woman who's in her early 60s to early 70s, right? For the average woman. So now you're adding estrogen, a prothrombotic agent, to a person who is aging. We all get more prothrombotic the older we get. It's part of the aging process. That's why when you see DVTs in people who aren't on hormone therapy, who aren't on like an estrogen or some other prothrombotic drug, just naturally occurring. How old are most of them? They're in their 60s or in their 70s, that type of thing. So that's why age 60, if they're seeking help for menopausal symptoms and higher, or 10 years from their LMP, 10 years into menopause, well, I guess it would be 11 plus years into menopause from last menstrual period, hormone therapy is not a good idea. And that was one thing, is because females have a lot of estrogen receptors in their brain. There was one thought that what would happen is that perhaps estrogen would be protective against dementia, and it does not appear to be so. So what about the risks and benefits with EPT and ET? Overall increased absolute risk. So let me try that again. Overall, there's an increased absolute risk associated with EPT, and ET are actually quite rare, less than 10 of 10,000 per year. It includes VTE and gallbladder disease. EPT carries a rare increased risk of stroke and breast cancer. If estrogen is inadequately opposed, there's an increased risk of endometrial hyperplasia and endometrial cancer. So you have a woman who has a uterus and you're tempted, let's just go with the estrogen, don't do it. It's not worth the risk. And that there are a number of other absolute risks reduced, like all-cause mortality, fracture, diabetes, breast cancer risk reduced with estrogen alone, as we just saw in that table. Now, hormone therapy, breast cancer risk, that is often what keeps both providers and patients from considering hormone therapy. According to NAMS, it's considered low, less than one additional case per 1,000 women per year of hormone therapy use, or 3 additional cases per 1,000 women when used for 5 years with CEE plus MPA, conjugated equine estrogen plus the Provera, because these are data extrapolated one more time from Women's Health Initiative, and that's considered level 1 evidence. Now, do you want to be the provider or the woman who's one of those extra cases? Absolutely not. But the risk is considered overall low. So clinical application, the patient should be counseled about risk for breast cancer with hormone therapy, and then put the data into perspective with the risk is similar to that of modifiable risk factors, such as 2 drinks of alcohol per day in women. That's a breast cancer risk factor. Obesity and low physical activity. Those are also all risk factors for the development of breast cancer. And hormone therapy influence on breast cancer risk is possibly dependent on a number of factors: the hormone therapy type and regimen, duration of HT use, prior hormone exposure, and individual characteristics. And select options and breast cancer screening when on hormone therapy. Remember that the hormone therapy will tend to have the breast remain a bit denser, and that could lead to the need for increased imaging, more breast biopsies, and potential delay in breast cancer diagnosis. So with estrogen therapy, what is the therapeutic goal? Is to use the most appropriate, often lowest effective dose of systemic estrogen consistent with treatment goals. So systemic estrogen can be any estrogen form that will be spread throughout the body. So it can be oral, it can be transdermal. And add an appropriate dose of progestogen to provide endometrial protection if the woman has a uterus. And the exception on that one would be using something like a CEE with a BZA, the estrogen receptor modulator, because that's going to do the job for the uterus as a combined tablet there. And then appropriate dosing for the progestogen for endometrial safety depends on the potency of the progestogen, the route of the progestogen, oral, transdermal, or possibly via a levonorgestrel IUD, something like a Mirena. I always use Mirena as my default example because that was the first levonorgestrel IUD on the market, but there are others. Estrogen dose used, and then the health outcome can depend on the type and the dose of the progestogen, the route of administration, and the type of regimen, whether it's sequential or combined, continuous combined. And then what you want to do is remember the sequential progestogen therapy will cause periodic uterine bleeding. Not a real period, but it's a shedding of the endometrial. And a lot of women they're like, okay, if I need to put up with hot flashes, if I need to think about being menopausal, what I don't want to do is have to deal with periods anymore. So one more time, going back to BZA for endometrial protection. And this is a selective estrogen receptor modulator. As I said before, it is combined with CEE to form a tissue selective estrogen complex. And we do have study that that combination is adequate for endometrial protection. And women using BZA plus CEE, unscheduled bleeding occurred more than 6 months after initiation should be investigated. In other words, what this should do is render the woman amenorrheic. But if she does have some unexpected bleeding after 6 months, you do need to think about going to further evaluation, as you would with any woman with unexplained postmenopausal bleeding. Excuse me. All right. So looking at the route of administration for estrogen, in treating vasomotor symptoms, systemic estrogen could be prescribed as oral drugs, transdermal patches, spray, gels, or vaginal ring. And remember with the vaginal ring is using the vagina as a drug delivery system, just like for combined hormonal contraception, the NuvaRing does that. Transdermal estradiol and oral CEE are similarly effective in alleviating those vasomotor symptoms, but clinical trials directly comparing the risk of coronary event like MI, stroke, breast cancer, and VTE associated with various estrogen routes and doses are lacking, but population-based studies suggest increased risk for VTE and PE with oral but not transdermal estrogen. All right, so I think I made the case. Estrogen prothrombotic. So why would using it like transdermal? Because a transdermal patch is the most common way that a non-oral estrogen is used. Why would it be that that transdermal would be lower clot risk than oral? And part of this is because oral meds, as the gut absorbs them, they go through the liver, that hepatic first pass effect. You all learned about that in pharmacology. But once it goes through the liver, it can activate some prothrombotic substances being produced by the body. Meds that are given transdermal, or for that matter, IV, rectally, vaginally, non-oral routes, do not undergo hepatic first pass effect, and therefore there probably, underline the word probably, is that lower observed VTE risk. That's why, all right? So with progestogens, they're available in a variety of forms, oral, injectable. Usually those are only used for contraceptive purposes, and that would be a drug like Depo-Provera. Combined transdermal patches with estrogen, combined vaginal rings with estrogen. One more time, that is more like the NuvaRing used for contraception rather than hormone therapy during menopause. And then via the levonorgestrel containing IUD. And what that can do is be helpful with contraception and avoiding problematic vaginal bleeding. So the non-oral routes possibly have those potential advantages that I just mentioned, avoiding hepatic first pass effect. But, well, what do we have for clinical trial evidence? Lacking on whether non-oral routes of ET or EPT are associated with lower risk versus oral routes of VTE, breast cancer, and cardiovascular events. So dosing principles with hormone therapy and the formulation, dose, and route of administration should be determined individually and reassessed periodically. Different HT doses, formulations, and routes of administration might have different effects on target organs, potentially allowing options for minimized risk. Apparently higher VTE risk with oral versus transdermal formulations, but the guidelines are not rigid at this point. So this gets into shared decision-making with the patient on formulation, route of administration. What I find a lot with hormone therapy is what I hear with things like birth control pills. You get the woman capable of reproduction who comes in and says, I want birth control pills, and my best friend is on this brand or this formulation. I want that one. Okay. And what it is the halo effect that the best friend has felt great on it. You could also get the converse. My best friend was on this one and she feels rotten. I want any of them but that one. All right. So a lot of times what people will do is with hormone therapy as well as with combined oral contraceptives, they'll be deeply influenced by what people around them are using. Okay. The dose of hormone therapy for menopause symptom management, adjustment tailored to symptomatic relief and adverse effects, and of course, the patient preferences. Periodically assess the need for ongoing use of HT. Should be based on individualized on hormone menopause symptoms, general health and underlying medical conditions, risks and treatment goals, and personal preferences, right? So one more time, looking at the evidence, level 1 evidence as recommended by NAMS, lower doses of hormone therapy can provide adequate symptom relief. I said this earlier. Remember, they were using in WHI, Women's Health Initiative, much higher dose of estrogen than we would use now. And so what you can see here are example of equivalent lower doses of hormone therapy. So not 0.625 milligrams of conjugated equine estrogen, if you were going to use that one, but only 0.3 milligrams. A lower dose of 17B estradiol, and the estradiol patch that's super low. Now, one of the things I have to point out to you here, because I am a pharmacology professor, you'll see that what it is recommended with an oral estradiol, the 17 beta estradiol, they're saying 0.5 milligrams or less. Okay. So let's just play with the number 0.5 milligrams. When you get to the patch dose is only 0.025 milligrams. All right. So why is the patch so much less than the oral? Because the patch doesn't undergo first pass effect because it's transdermal. And the oral will undergo hepatic first pass effect, where the liver picks up a bunch of the drug and just tosses it to one side. And the lowest dose approved for estradiol weekly patch appears to be effective in vasomotor symptoms. So they're even saying, wait a minute, we've got even more data that a super low dose estradiol patch will do the job, Yet it's not FDA approved for that, but it is its FDA approval is only for the prevention of osteoporosis at this time. Hold on one second. I'm sure they'll get the vasomotor indication on that one. So here is a quick table. If you're looking at all of this and you're saying, oh, wait a minute, I hear about all these different products, etc. How is it? What is it I do here? What is it I do here? And what you have to do is just be familiar with these. What are we very often dependent on? What will the insurance cover? No two ways around that one. Some of these are branded. Many of these are not branded and they are generic. So go with formulary. But this is a really, really helpful table. Excuse me, I just inhaled something. Okay, try that again. This is a great table on estrogen products. And what do we want to look at here? We want to be thinking for the estrogen dose. I'm not going to go over each one of these. For the estrogen dose, you want to be going with the lower dose. I think I've made my point on that one. And that whether you're doing oral, transdermal patch, transdermal gel, or the vaginal. So you want to keep that in mind. This can be very, very helpful for looking at and saving, because what ends up happening, of course, is we sometimes are dictated by what the patient's insurance will pay for, correct? Unfortunately, that's the way it goes in healthcare these days. And Counseling on postmenopausal hormone therapy. The patient has no contraindications to its use and desires to start hormone therapy ASAP for hot flashes. The NP advises that approximately what length of time will be needed prior to noting an impact on vasomotor symptoms. So this is part of patient counseling. They're going to want to know, when am I going to feel better? Would it be A, within a few days? B, within 1 to 2 weeks, C, 3 to 5 weeks, D, 6 to 8 weeks. In other words, how quickly does this stuff kick in? And the correct answer is going to be, it's going to be about 6 to 8 weeks. They might notice a reduction in severity of vasomotor symptoms, but not necessarily a lowering of the frequency until they're on it for a couple of months. What about looking at the progestogens? The rationale for use in hormone therapy is to counteract the proliferation effects of systemic estrogen on the endometrium. The appropriate route, dose of the progestogen for endometrial safety depends on the potency of the drug, the estrogen dose used, and that there is evidence, growing evidence, that what we're seeing is that progestogens alone will be helpful in vasomotor symptoms. You know, there are patients that are just terrified at the idea of taking in an estrogen, particularly if they've had a family member with a breast cancer, something along those lines. So again, for products that have both an estrogen and a progestogen in them, you can look at this list here. One of the things I want you to remember on this one is what was used during WHI. It was that Prempro, the CEE with progesterone. And that was actually the #1 selling drug in the United States during the 70s and 80s. It really was. It was pretty amazing how commonly it was used. And you can see nice option down there of estradiol with levonorgestrel or estradiol with norethindrome in the patch, the transdermals. And those are great because they're either once a week or twice a week. What are the contraindications to hormone therapy? Active liver disease, unexplained vaginal bleeding, high risk for stroke, including untreated or poorly controlled hypertension, a history for estrogen-dependent cancers, regardless of location, breast cancer. Now, let's say that you've got a woman who's acutely symptomatic. She had breast cancer. She's now like in her late 40s. She unfortunately had breast cancer in her early 40s. Remember, not all breast cancers are estrogen dependent. I would never prescribe anything like hormone therapy unless I was in touch with oncology and got an idea of what their thoughts were on it. But, you know, that's something that we do need to keep in mind. At DVT, don't use it in a person who's already showed you that they can clot. Just don't. ASCVD and equivalents like heart disease, MI, TIA, CVA, and endometrial cancer, except for stage 1 without deep invasion. Oh yeah, I'd be letting somebody else make that decision whether hormone therapy would be appropriate or not. Yeah, no, I wouldn't. That would be, I would defer to oncology on that one. Another relative contraindication is hypertriglyceridemia when the triglycerides are greater than 400. For those of you who are not in primary care and aren't familiar with what triglycerides, what desirable triglycerides are, it's less than 150. And the lower, the better. Triglycerides go up in insulin resistance. Triglycerides go up in poorly controlled diabetes, and in untreated or undertreated hypothyroidism. So whenever I hear about anyone, regardless of birth, sex assignment, et cetera, that they have high triglycerides, I always think about a potential secondary cause. The other thing that will boost up triglycerides is heavy alcohol use. Active gallbladder disease and elevated cancer risk. Those are all relative contraindications. to hormone therapy. So what about progestogen only formulations for vasomotor symptoms? It actually has been found to be effective. So some doses there for the MPA 10 milligrams, and that you can look, though, there are no long-term studies have been done to assess the safety of progestogen only treatment for menopause symptoms. Micronized progesterone 300 milligrams nightly does significantly decrease vasomotor symptoms compared to placebo and improves sleep. Synthetics progestins have been shown to have some benefits on that, but one of the things is we don't have the long-term studies like we do from on the combined estrogen progestogen like we do on progestogen only, but they are a really nice option, particularly for a woman who is saying to you, I just don't want estrogen near my body. Okay, what about compounded bioidentical hormones according to NAMS? Now, this is one of the things. Remember, North American Menopause Society is pretty much where do we have buckets of the evidence, or where do we have FDA approval, or if we don't have FDA approval, what we at minimum have is literally decades of observational safety, like looking back at Women's Health Initiative. So I'm telling you what NAMS has to say. I also respect the fact that this is a growing body of knowledge. And if I was to do this program in 5 to 10 years, might have some different information for you. But right now, what I'm doing is I'm going by what NAMS says. And quite frankly, one of the reasons why I'm sticking pretty close to what NAM has to say is this is how you get insurance to pay for hormone therapy, is by doing what is within the NAMS guidelines. And in fact, that's really helpful if you run into a roadblock with getting something paid for, and you have to do prior authorization, is to quote the NAMS guidelines and say, this is why I've chosen this product for this particular patient. Sometimes that will move approval along. By the way, that will work with almost any drug, is if you're trying to get a particular drug for a patient and you run into the roadblock of prior authorization, to the most dreaded words in healthcare, right? Prior authorization. What you might, adding a quote from a set of guidelines, I have found often moves things right along. So compounded bioidentical hormones, there are caution when considering these: minimal government regulation and monitoring, overdosing and underdosing, presence of impurity, lack of sterility, lack of scientific evidence and safety data, and lack of labeling outline the risks. They consider this level 1. Again, what you have to do is just consider the source of this. But I also believe that this is important. And we also know a lot of compounded bioidentical hormones are promoted and provided over the internet. Trust me, I adore telehealth. Don't get me wrong on that one. Love it, love it, love it. And as a newer telehealth provider, like newer, I fell into it during COVID, like many of us did. I am thrilled with what I can accomplish in a patient visit with telehealth. And because at first I was like, how the heck is this ever going to work? But have really seen the benefit of it. But on the other hand, a lot of times when you're talking about compounded bioidentical hormones, you've got a patient who might have some contraindications or relative risk for taking hormone therapy. They've got a remote provider who doesn't have the whole picture. It can be a little on the challenging side to say to a patient, this is a reputable company or not. And there are reputable companies, don't get me wrong. So compounded bioidentical hormone therapy, when to use. Part of this is you have to do that whole shared decision making. And I'm talking to you all, I'm talking to you like a primary care provider. I know you're not all primary care providers, but patient preference alone should not be used to justify the use of compounded bioidentical hormone preparations, particularly when government regulated hormone preparations that are bioidentical are available. Micronized progesterone is a bioidentical hormone, and situations in which compounded bioidentical hormones could be considered if they've got allergies to ingredients of government approved formulations or doses aren't available for government approved products. So what about hormonal testing according to NAMS? Their general principles are salivary and urine hormone testing to determine dosing are not recommended. Serum hormone testing is rarely needed. So why are they just kind of throwing all the testing out the door? Is the rationale for that is the testing is unreliable due to differences in hormone PK, pharmacokinetics, and absorption, diurnal variation, and intra-individual variation, and proper evaluation, including menstrual history, symptom record, can guide appropriate dosing. So really what they are saying is diagnose menopause clinically, not by labs, but you will get asked by patients to quote, check my hormones, and we all know that that happens, but you're better off doing it by history and physical. So true or false with hormone therapy? Vasomotor symptoms return in about 50% of women when hormone therapy is discontinued. True or false? And that's true. That's true. There's no consensus about whether stopping abruptly or gradually tapering the dose of hormone therapy is preferable. And that's also true. I'll read one article that says taper it off and the other that says just go ahead and you can stop it. You can stop it. So what about consideration of some non-vasomotor symptom issues? Sleep disturbances during menopause transition. Women with vasomotor symptoms are more likely to report disturbed sleep, and HT improves sleep in women with bothersome nighttime vasomotor symptoms by reducing nighttime awakening. And estrogen in and of itself appears to have some effect on sleep independent of vasomotor symptoms. I hear this all the time from my patients, all the time. So, and you can just see here a study done on sleep duration and quality in women in the menopausal status. And this was in women who weren't on medication, but what it looked like for them. Genitourinary symptoms. This is a major issue. Low-dose vaginal estrogen preparations are effective and safe for the treatment of GSM, genitourinary syndrome of menopause. They have minimum systemic absorption. And by the way, GSM was formerly known as vulvovaginal atrophy, atrophic vaginitis, urogenital atrophy, or my fave. This was discarded a few years ago, but I still hear the term used, senile vaginitis, which always gave me a little mental image of a slightly confused vagina, not knowing where it belonged. But this is, by the way, my image of that little senile vaginitis, poor little vagina walking around, it's so outdated that it's walking the halls of the hospital and it's wearing a posy vest. Some of you might not even know what those are. We used to tie people into bed with posy vests, and the posy vest is hanging behind it. And changes in the GU tract include urethral as well as vaginal dryness, dyspareunia, reduced lubrication. Okay, reduction in lubrication, that can be treated, of course, with a lubricant. But how many of your patients in this perimenopausal, postmenopausal age have you seen who come in and say, it burns every time I pee? You check their urine is as clear as a bell, just crystal clear, no white blood cells, okay? Yet it always burns to urinate, but they also don't have that much in the way of frequency and lower abdominal discomfort that often goes along with the UTI. And getting some estrogen back into the periurethral area is like a miracle. For women with breast cancer, oh, by the way, vaginal or localized estrogen is preferred over systemic therapies when ET is used only for GU symptoms, like there aren't other symptoms bothering the woman, or they might not be a good candidate for systemic estrogen. And a good example of that would be a woman in her 60s, rare, if any, hot flashes, a number of years post-menopause, 10 plus years post last menstrual period, but is complaining about that urethral burning. And for women with breast cancer, low-dose vaginal estrogen should be prescribed in consultation with oncologists. A lot of times it works like a charm. It works like a charm, and oncology will improve it because so little of the estrogen is absorbed. This is one of my very favorite things to prescribe for postmenopausal vaginal symptoms for recurrent UTI prevention in women in menopause. And the definition of recurrent UTI in this population would be 3 or more culture plus symptomatic UTIs in 1 year or 2 UTIs in 6 months. The recommendation is intravaginal estrogen. You can do it with estriol vaginal cream, 0.5 milligrams, used daily for 2 weeks, then twice a week as maintenance therapy. Now, let me give you another example of this. By the way, this is off-label, but it's something I've done for years. Let's say that you have a patient who would have difficulty delivering vaginal estrogen to themselves. But what they could do is take a dab of vaginal cream and rub it around the urethra. Okay, a cup daily for 2 weeks, then twice a week as maintenance. I have found that has worked. You know what other patient population this works in? Is older women with recurrent UTIs who have cognitive issues, who would be unable, like dementia, unable to deliver intravaginal estrogen to themselves. And if they have a caregiver, to then have that caregiver deliver an intravaginal estrogen would not be understood by the patient. And you wouldn't want to see somebody with cognitive issues wonder, why does somebody a couple of times a week put something in my private parts? So I've even advised family members is that, particularly if this is an older woman who needs help with personal hygiene and might reluctantly gotten accustomed to somebody helping them wash their genital region, is to say, okay, wash as you would, very gentle soap like you would recommend with any postmenopausal woman, and then take a dab of the estrogen cream on a damp face cloth and just kind of swipe it up, swipe it up from the urethra over the area and deliver the cream that way. And I've had many, many, many older women help avoid UTIs by doing that. So Beer's criteria, true or false? If you're not familiar with Beer's criteria, this is one of a number of different guidelines that help us advise us on using different meds or not using different meds with older adults. True or false? There is evidence that vaginal estrogens for the for the treatment of vaginal dryness and UTI prevention is safe and effective in women with breast cancer, particularly at the typical recommended doses. And the answer there is true, okay? So what about progestogen therapy is not required with low-dose vaginal estrogen, but randomized controlled data is lacking beyond 1 year. And non-estrogen prescribed prescription FDA-approved therapy that improve vulvovaginal atrophy in postmenopausal women include the drug fheaa in intravaginal DHEA or Intrarosa. So there are estrogen-free formulations that are available as well. The non-estrogen containing preparations tend to be very expensive. The other thing to keep in mind is sometimes I'll get pushback on the estrogen cream saying, but whoa, that was a big copay. The thing is, with the big copay, if you're only doing that dab of estrogen cream around the urethra, one tube will last like 6 to 12 months. It will. So it's a big copay, but you don't have to use the vaginal applicator. It can be really helpful. So what is Osphena? The mechanism of action, it acts like an estrogen on vaginal tissue, stimulates the endometrium, and causes it to thicken. With all menopausal therapies, it is prescribed for the shortest duration, consistent with goals and risks. It does have a boxed warning per the FDA, and with the prothrombotic parts of this too, an increased risk for DVT. Okay. By the way, it acts like an estrogen on the vaginal tissues. And remember, that's really why we are prescribing it. Contraindications to us, Osphena is undiagnosed vaginal bleeding, known or suspected estrogen-dependent neoplasia, the whole clot business, any DVT, PE, active arterial thrombotic disease like ASCVD, known or suspected pregnancy, or any hypersensitivity to the product like we would with any kind of a drug. And it's approved for that moderate to severe dyspareunia. That's its only indication, which is, it's a good indication, but adverse effects, hot flashes, vaginal discharge, muscle spasms, genital discharge, and excessive sweating. So that can be a limitation of it as well. Now, what about intravaginal DHEA? Now, what I'm specifically talking about here is the prescription product, because I have seen this sold online, intravaginal DHEA suppositories that are sold OTC. So I'm specifically limiting my comments to the prescription product. Again, it's got the moderate to severe dyspareunia and vulvovaginal atrophy type of indication, clinical effects. It converted estrogens and androgens in the vaginal tissue, and that helps decrease the vaginal pH, decreases dyspareunia, thickens up the vaginal tissue. Direct comparisons to Intrarosa and vaginal estrogens is lacking, and OTC vaginal DHEA vaginal tablet use by NAMS is not recommended. So what about pelvic floor disorders related to menopause? Systemic hormonal therapy doesn't improve urinary incontinence. And in fact, it might even increase the risk of stress incontinence. This is something that's been known for many, many, many years. Low-dose vaginal estrogen therapy might be helpful in improving vaginal symptoms, such as recurrent UTIs, overactive bladder, and urge incontinence, but there's no form of hormone therapy has the FDA indication for urinary health. Long and short, what you need to consider is a urological evaluation for really problematic stress incontinence, a pelvic floor disorder, or the like. What about sexual function and hormone therapy if sexual function or libido are concerns and the woman with menopausal symptoms? Transdermal estrogen might be preferable over oral estrogen, because here's something that happens with oral estrogen. Oral estrogen boosts the sex hormone binding globulin levels. And what that can do is bind free testosterone and lower testosterone levels. Please note the word might. This is a direct quote from NAMS. Not all that sure. But this is, how if you had, let's say, a teen woman in her early 20s who has significant acne, and one of the therapies considered for that would be to go on combined hormonal contraception, right? Okay. So what birth control pills do to help with acne is they lower androgen levels through the estrogen supplement. And regardless of birth sex assignment, we get a lot of our sex drive out of our androgen or testosterone levels. So those go down as women age. So transdermal might be better if one of the big complaints is loss of libido, poor sexual function. And both systemic hormonal therapies and low-dose vaginal estrogen increase lubrication, blood flow, and sensation in the vaginal tissues. And one thing is systemic hormone therapy generally doesn't improve sexual function. And what you might need to do is prescribe both systemic and some localized estrogen to help with the lower vaginal issues. Low-dose vaginal estrogen has been noted to improve sexual function in women with genitourinary syndrome of menopause. There's actually limited data to support testosterone for this purpose. Non-estrogen alternatives for dyspareunia include what I just mentioned, the products like Osphena and Intra-Rosa. Now, what are some other potential benefits of hormone therapy? On the skin, estrogen therapy appears to have beneficial effects on skin thickness and elasticity and collagen when given at menopause. And you know what I'm starting to see in this is some stuff coming through my social media feed about buying a topical estrogen cream for the skin. We don't have a lot of evidence on that, but that's been a theory that's been thrown around for many, many years now. Hair changes in hair density and female pattern hair loss worsens after menopause. It doesn't look, we don't have the evidence on whether that's helpful, whether hormone therapy will help with that or not. Benefits on eye health and hormone therapy appears to decrease the risk of neovascularization and soft drusen formation that we see in age-related macular degeneration, but not in early or late stage macular degeneration. So it might reduce the risk, but once the problems, the changes in the eye with macular degeneration are there, doesn't look like it's doing it going to be helpful. There's actually there is actually some research being done now to see in women who are very, very high risk for macular degeneration about doing an estrogen insert into the back of the eye. And, keep your ears open for that one. I think we're a number of years from that now. And estrogen therapy appears to reduce intraocular pressure and mitigate the risk for open-angle glaucoma in women of African ancestry. By the way, women, people of African ancestry and people with type 2 diabetes are the highest risk group for the development of open-angle glaucoma. And I believe the study has been limited and it just hasn't looked at wider population. And the effects of hormone therapy on there's evidence that hormone therapy has effects on cataract, optic nerve disease, dry eye disease, and hearing loss. All of that is mixed. So what about bone loss and bone health? Hormone therapy helps reduce bone loss in healthy postmenopausal women with dose-related effects on bone density, reduces fracture risk in healthy postmenopausal women. Discontinuing hormone therapy results in rapid bone loss. However, interestingly, it doesn't look like there's increased risk of fracture from women in the Women's Health Initiative after discontinuation. Hormone therapy some formulations are FDA approved for bone loss, but not for the treatment of osteoporosis. So this is important, that estrogen looks like it helps reduce bone loss, but can't help build bone, which we might want in osteoporosis. And the absence of contraindications in women age less than 60 years or within 10 years of menopause onset. Systemic hormone therapy is an appropriate therapy to protect against bone loss. So you'll see that we're being told here it's bone loss, it's not to treat osteoporosis. So unless contraindication, women with premature menopause without prior fragility fracture or osteoporosis, it is recommended that part of their therapy be hormone therapy or combined hormonal contraceptives like estrogen, progestin, unless otherwise contraindicated, to prevent bone loss and reduce fracture risk. That's preferred over other bone-specific treatments. Continue until the average age of menopause and then reassess. I'm going to talk for a moment about the difference between birth control pills and postmenopausal hormone therapy and what the drug doses are there. But so one more time, if you had a woman who had cessation of menses at age 40, okay, premature menopause, certainly investigate that. Certainly investigate that. But it would be perfectly appropriate to prescribe hormone therapy on that until she is 50, 51 years old, age of naturally occurring menopause, in part to help her maintain her bone density. And decisions about initiation and discontinuation of hormone therapy should be made primarily on the basis of extraskeletal benefits, like the reduction of vasomotor symptoms and risks. So let's get down to this. What's the difference between a package of birth control pills and a package of postmenopausal hormone therapy? Hold for 1 second. I just want to close the door. My husband's in another room. He's on a business meeting. You might not be able to hear this, but I'm thinking it might be radiating to here. There we go. Okay. Okay. So estrogen equivalents, hormone therapy versus COCs, combined oral contraceptives. So we're looking at, we've got two. One would be given for contraceptive benefits. That's combined oral contraceptives. And the other hormone therapy, which would be used for treatment of menopausal symptoms. When combined to low dose postmenopausal hormone therapy, like the example would be CEE at 0.3 milligrams, literally half of what was used in the Women's Health Initiative. The estrogen equivalent of a combined oral contraceptive pill containing 20 micrograms ethinyl estradiol, in other words, the lower estrogen dose birth control pills that are most commonly prescribed now, is at about what level? So 0.3 of milligrams of CEE versus 20 micrograms of ethinyl estradiol. What would the equivalent be? Would it be A, about the same estrogen equivalency, B, about 2 times the estrogen dose in the birth control pills compared to the hormone therapy, C, about 3 times the estrogen dose of the birth control pills versus the hormone therapy, or about 4 times the estrogen pro-thrombotic, potentially pro-breast cancer. Yeah, it takes a while, but never give more estrogen than you need. And I just have to say one aside about birth control pills. Most of the hormonal benefit, I'm sorry, try this again. What I have to say about birth control pills, most of the contraceptive benefit of the birth control pills come from the progestin side, and the estrogen is there along for the ride, and mostly to cause cyclic shedding of the endometrium, if that's in fact what the woman desires to have when she's on birth control pills, right? So when we're looking at this, just remember the combined oral contraceptives, we're going to have about 3 to 5 times the estrogen form when compared to low dose hormonal therapy. Another table here that will give you an idea of dose equivalent. So when I talk about conjugated equine estrogen at the high dose, 0.625 milligrams, it's the same as estradiol at 1 milligram, and you can see the rest of them there. All right, what about diabetes and hormone therapy? Hormone therapy significantly reduces the diagnosis of new onset type 2 diabetes. It's not FDA approved for this indication. It might attenuate the abdominal adipose accumulation that is seen as women get older and menopause-related weight gain with small effect. I remember one of my patients saying to me, I hit 51 and there were 10 pounds sitting on my front porch waiting to hop onto my body. And she said, it's like, I don't know what the heck happened. All of a sudden, I just put on 10 pounds. Hormone therapy can be prescribed in pre-existing type 2 diabetes in the absence of any of the other contraindicating health issues. And you might actually see benefits in terms of glycemic control when used for menopause management because the estrogen is insulin sensitizing. Cognitive function, the effect on hormone therapy might be modified by baseline cognitive function. More favorable effects are seen in women with normal cognitive function prior to hormone therapy. They'll find that their thoughts are a little clearer. And estrogen therapy might have cognitive benefits when initiated immediately after hysterectomy with bilateral oophorectomy. Hormone therapy in early natural postmenopause period has neutral effects on cognitive function. So this is the citation for non-hormone therapy and from NAMS. And all of these, by the way, are open access. You can just go to the links I've provided for you and read the entire statement. What I've done in this program is try to give you a really distilled down version of this. So what they say is for non-hormone therapy in menopause. Hormone therapy, we've been through it, remains the most effective treatment for vasomotor symptoms, should be considered in menopausal women within 10 years of their final menstrual period. We went through this before. Just don't really think about adding estrogen when a woman is 60 years or older or more than 10 years from her LMP. Reason for using non-hormonal therapies, personal preference might be part of it. Contraindications like estrogen-dependent malignancies, ASCVD, others. And it'd be really important, this is a direct quote from their document, that healthcare professionals be well informed about non-hormone treatment options for reducing vasomotor symptoms that are supported by the evidence. And so some of the things, remember, lifestyle modification that are helpful, might be helpful individually, but I will tell you, remember, this is NAMS, they're really cut and dry, they want to see the evidence, might be helpful, no significant risk, cooling techniques, avoiding common vasomotor triggers, exercise, yoga, but I can't give you 15 research studies that say that this is helpful. But some of it is like common sense. Okay, what do we all do when we get into the shower? We tend to take the hottest shower we can tolerate, right? Because that feels delicious. It does. It feels really good. And what we should be doing with women with menopausal symptoms is saying to them, take the coolest shower you can tolerate, because hot showers are often a trigger for menopausal symptoms. I have a group of women in my practice who had all worked at the same commercial laundry for a number of years. It's hot, it's humid, and they all seem to hit menopause at the same time. And they were just about croaking with hot flashes because they were in a hot, humid environment all day long. And I would tell each and every one of them, before you go to work in the morning, take a cool shower. Take a cool shower and see if that helps. And almost to the person, they said, yeah, it didn't get rid of my hot flashes, but boy, they're a lot more manageable. Plus, it's better on aging skin. Aging, they were only in their 50s. But you know what I mean, is the skin does tend to get drier as we get older. Healthy diet is important for both health promotion and chronic disease prevention, but there isn't a lot to say that one diet versus over the other is helpful with vasomotor symptoms. Weight loss can be considered is with obesity, vasomotor symptoms tend to get worse. But you'll also notice that patients with a higher BMI will often say that the heat bothers them more just in the day-to-day. Cognitive behavioral therapy can be helpful, and clinical hypnosis has been shown to reduce vasomotor symptom frequency and severity. And that limited data to support the following: mindfulness-based stress reduction. Vasomotor symptoms invariably go up more when a person is stressed. Okay. And so not a lot of evidence on that because of small sample size and lack of control groups. Same thing with paced breathing and relaxation techniques. My thought is, if it helps the individual, what is the harm? The harm is zero. There are data to support cognitive behavioral therapy to reframe thoughts and beliefs on menopausal symptoms. And what are some common thoughts and beliefs on menopausal symptoms? As beliefs about hot flushes being embarrassing in a social situation, feeling vasomotor symptoms will never end, and feeling the feeling of being unable to cope. If waking up with a vasomotor symptom, being unable to fall back to sleep, then suffering the next day due to poor sleep. I mean, you know what? One of the things that I like to see, I don't like to see anyone suffer with anything, but one thing I've noticed more often now when I've just been out, like I was someplace not long ago. Where were we? Oh, we were just out to dinner with some friends. And I was rather encouraged to see a woman who I'm going to guess is maybe in her 50s, sitting at dinner. It was actually a rather nice restaurant, and she's got a fan, and she's fanning herself back and forth. I could tell by the flush that she's having a hot flash, but she is sitting there and she is enjoying herself and doesn't seem to be bothered by it. And I see that more often now. I will also notice she was drinking a glass of wine. I'm not making a judgment on this, but alcohol is a common vasomotor trigger. All right, so what about the non-hormone therapies for my vasomotor symptoms? These provide mild to moderate effectiveness. When compared with the hormones, they're just not as potent. So with the SSRIs, the only one of these that has a FDA indication for the use in menopause management is the paroxetine salt at the 7.5 milligram dose. Its brand name is Bristol. It's been generic for a number of years now. But it's much more expensive than just plain the 10 milligram paroxetine. Okay. So can I tell you that 7.5 and 10 milligrams, it's dose equivalent? No, because it really hasn't been studied, but I have to tell you, I often do prescribe just the 10 milligram paroxetine. But one thing to keep in mind with paroxetine, it does have, out of all the SSRIs, it does have some drug-drug interactions. It's a cytochrome P452D6 inhibitor, so you have to double check on that. It's also the most sedating of the SSRIs. So if you discuss this with your patient, they want to give paroxetine a go, dose it at bedtime. Citalopram and S-citalopram, also there's evidence that that's helpful, but there's no FDA approval for that. And S-citalopram is always a great SSRI to keep kind of in your back pocket because it's the SSRI with the least drug interaction part. Now, here's something I need to mention, and I'm going to throw the SNRIs like desvenlafaxine and venlafaxine into what I'm about ready to say. Remember, SSRIs, SNRIs can render a patient, even in lower dose, regardless of birth sex assignment, anorgasmic or with delayed orgasm. Okay. And so please be aware of that being an adverse effect. I've seen that where the patient came back and says, yeah, it helped with the hot flashes, but it's a no-go. I can't reach orgasm anymore. It's very frustrating. Okay. Desvenlafaxine, which is brand name Pristiq. It is an isomer of venlafaxine. They're pretty much the same thing. And what you can see is with these, compared to the doses used for the treatment of depression, with both the SSRIs and the SNRIs, the doses used for menopause management are significantly lower, at least to start. And then you can titrate up. So please be familiar with what the regular dose is if you were treating a depression. Now, gabapentinoids, gabapentin, there is observational study that gabapentin is helpful in menopause management, hot flash management. One more time, it's not FDA approved for that. And what do we know with gabapentin? I'm to the point with gabapentin where I go like, what won't it cure? Okay, you can, because it's used for so many different things, particularly off-label, you could go as high as 2,400 milligrams a day, but generally what you will find is a much lower dose is helpful for menopause management. Now, there is an additional non-hormonal treatment for menopause, and that's fheaa. And this is a newer drug in its treatment for moderate to severe vasomotor symptoms due to menopause. It is a neurokinin 3 receptor antagonist. It interacts with gonadotropin releasing hormone that's involved in maintaining body temperature control. And it's one of very few non-hormonal drugs approved by the FDA to management of menopause. And therapeutic benefit, it is that hormone-free alternative for women who should avoid hormone therapy, like those with breast cancer, prior stroke, thrombosis. It does reduce the risk of and severity of hot flashes day and night, improves quality of life, fewer nighttime awakenings. And what you can see is there is a reduction in daily hot flashes, but placebo also reduced daily hot flashes. I'm going to leave that be there. But these were also patients who were having 7 moderate to severe hot flashes a day. These poor souls were just flashing up a storm. Most common adverse effects: belly pain, diarrhea, insomnia, back pain, hot flush, and perhaps elevated hepatic enzymes. The cost for a month's worth is $570, okay? And you could see, compared to other meds, significantly more expensive. Non-hormone menopause treatment options that are not recommended due to lack of evidence and or benefit versus risk ratio are things that you might say, well, gabapentin, pregabalin, they're adjacent drugs, but there's no evidence that pregabalin or Lyrica is helpful. Clonidine, the old school blood pressure med, not used all that often, at one time was recommended for menopause management. Not a lot of evidence and a lot of adverse effect. And the drug oxybutynin. So what about nutritional and herbal resources? Mixed evidence on adding soy to the diet. And one of the reasons is most of the clinical trials that have looked at soy, there's like a molecule of soy in it. There's just not all that much. Over-the-counter supplements, including black cohosh, and that's given the lack of rigorous evidence-based scientific research. These remedies are not recommended, and cannabinoids not recommended for the treatment of vasomotor symptoms. Could be in the future, okay? Evidence does not support the use of the following. And sometimes, you know, like I said, this is North American Menopause Society. I've every bit of respect for their work, but what they want is like 15 feet of evidence before they'll say anything is good. But this might help in the individual, but there can't be a wide comment on it. Acupuncture, electroacupuncture, or chiropractic intervention. Pain management can be helpful, which is doing a stellate ganglion blockade. It involves injecting an anesthetic agent into the lower cervical or upper thoracic region. And it has been, you know, it's going to be associated with the potential risk of injecting into that region. So I want to thank you for your time and attention. We got a lot to consider. We went through a lot there. I've got one question that came in. What about compounded bioidentical formulations? I did mention that. Again, this is North American Menopause Society. They're pretty cut and dry on this. And the other part of that is it truly bioidentical? And is it a reputable compounding pharmacy? I think over the next few years, truthfully, we are going to be having more evidence on this. And if I had a patient that said, I want bioidentical hormones, okay, but and I'm in an FQHC, so you bear with me on this one. I have to go with what my patients can afford. And for the most part, they can't afford to do a lot of out-of-pocket expense for medications. And if they said to me, I looked into bioidentical hormones, in a perfect world, that's what I really would like. I can't afford it. What I would do is inform them of what I included in the program here about how the experts in this do not advocate for that. And then I'd say, however, we've got micronized, and this is a woman who has a uterus, micronized progesterone that is a true bioidentical hormone. And if you look at the supplement of the prescription estrogen forms, which one is converted in from its parent compound to what the body largely makes? It'll be estradiol. So what I could say is we can go with the micronized progesterone and then say a little prayer to the prior authorization gods. Don't get me started. And then try an estradiol preparation. And my preference would be to do a transdermal estradiol to avoid that hepatic first pass effect. As I mentioned before, avoid triggering that clotting mechanism. Okay. I think that was it for questions. How about we do this? It's 1/4 Why don't we take about a 15-minute break? And I'm going to turn off audio and I'm going to turn off video. Please remember questions to me into the Q&A box. And I'd be happy to start our next program with me going over any of the questions that came in. Thank you.